Hello! Today we are going to speak about one of the most spreading group of infectious diseases, like, as you see, respiratory tract infections. And particularly we will speak about influenza, meningococcal infection, and diphtheria. I hope you understand. Так. And in general, now we will speak about, we will remember about the anatomy of respiratory tract. As you see, yes, the upper respiratory tract that includes the nose, paranasal sinuses, and throat. The respiratory airways. This includes the trachea, bronchi, and bronchioles. The lungs include respiratory bronchioles, alveolar ducts, alveolar sacs, and the alveoli. I hope you remember, you all remember about such very common and similar organs, but respiratory infections exactly influence on all these organs, and that's why try to remember and imagine now exactly the respiratory bronchial tree, as you can say, and also the upper respiratory tract. We cannot speak about the respiratory infection without the possible mechanisms of defense that they produce during their own life, during their development, and so on. Exactly the agents. I hope you remember that particles from 2 ultrameters to 0.2 ultrameters can go all the way down inside the alveoli, avoiding the defense of the upper respiratory tract and the mucociliary elevator. Note, most bacteria and all viruses are 2 millimeters and smaller. The following defense mechanisms in the alveoli protect the parenchymal cells from invasion by microorganisms, like alveolar macrophages, the most important, complement components, alveolar lining fluid containing surfactant, phospholipids, neutral lipids, IgG, immunoglobulin G, immunoglobulin E, A, and secretory immunoglobulin A, certain complement components, factor B, and other unidentified agents that may be important in activation of alveolar macrophages. B cells, T cells, and null cells that can elicit a localized immune response to infection. Lymphoid tissue associated with the lungs. Once a microorganism arrives in the alveoli, it can be opsonized by immunoglobulin G in the fluid lining the alveoli. These organisms will then be ingested by macrophage. If no specific antibody to the organism is present, then the macrophage may still be able to phagocytize the invader, however, in a slower rate. Once the microorganism is phagocytized, the macrophage will destroy the organism, if it can, and present microbial antigens on the surface to evading B and T cells. Once activated, the B and T cells can produce more antibody and or activate another macrophage. Meanwhile, the macrophage is also releasing factors that help bring in polymorphoneutrophils from the bloodstream and initiate an inflammatory response. Along with the polymorphoneutrophils come more antibodies and complement components useful in destroying the invader. The invader can also at this time leave the lungs and get into the general circulation. This is probably why systemic signs of infection, fever, malaise, myalgia occur during pneumonia. Mechanisms used to avoid phagocytosis by invaders used to avoid normal defense mechanisms of the lungs. To kill the microorganism in the alveoli, it must be phagocytized by the alveolar macrophages. If these microbes can avoid phagocytosis or survive once phagocytized, they can survive in the lungs. Microorganisms have developed a number of ways to avoid phagocytosis. One phagocytized certain organism can survive in the phagocyte. And as you see, what they produce. Capsule production. It's character for Streptococcus pneumoniae, Haemophilus influenza, Bacillus anthracis, Neisseria meningitis, Klebsiella pneumoniae. Toxin production. Yes, this toxin could include cytotoxins, leukocidins, exotoxins, for example, Staphylococcus aureus, yes, the most resistant and bacteria that can cause very serious nosocomial infections, produce leukocidins and cytotoxins. Pseudomonas aeruginosa produces exotoxin A, which destroys cells much like the diphtheria toxin does. We will speak about diphtheria a little later, but would remember that exactly diphtheria produce also exotoxin that can destroy the cells. That's why lead to the fibrosis and necrosis fibrosis. Being too large to be phagocytized, parasites and fungi are often too large for the phagocytes to engulf. Replication inside the cells. Viruses and chlamydia are obligate intracellular parasites, and a lot of rickettsias, I hope you remember, that replicate inside the cells of the lung, avoiding the phagocyte. And also mimicry. Some parasites produce surface proteins which are very similar to host proteins or acquire host proteins and appear to the phagocyte itself. Some bacteria produce proteins that cause host proteins to bind to their surfaces, for example, also again like Staphylococcus aureus. Mechanisms used to survive inside the phagocyte. Inhibition of lysosome fusion with the phagosome. Character for Toxoplasma gondii, Aspergillus, Chlamydia. Escape from the phagosome. Character, yes, for Mycobacterium lepra, I hope you remember, Trypanosoma cruzi, influenza virus, escape the phagolysosome. Resistance to killing and digestion in the phagolysosome. Mycobacterium tuberculosis, Nocardia spitaceae, Yersinia pestis, resistance, yes, and to killing and digestion. Growth in the phagocytic cell. Character for Mycobacterium tuberculosis, Legionella, cytomegalovirus. Entry into the phagocyte other than be phagocytized. Some organisms avoid destruction by getting into the phagocyte's cytoplasm. Non-phagosome-lysosome fusion occurs and the organism can survive in the phagocyte. Character for Toxoplasma gondii and some analoged Heterodyne viruses. And now we will speak more exactly about respiratory infections. And you see, yes, to such infections belong about 20% of all human infectious diseases. And now, as you understand, yes, maybe such percentage even increased due to the COVID situation. Yes, I didn't list the COVID here because maybe we will have a separate lecture about COVID. Influenza, one of the most often and dangerous also diseases. Measles, very dangerous in the childhood, but now it's ruled infection. What does it mean? It can be like prevented by vaccination. Pertussis, the same like measles. Chickenpox also. Rubella, yes, maybe not so dangerous for exactly for adult already humans, like disease, but dangerous for pregnant women, for fetus, causing the very serious congenital infection. Scarlet fever, it's already like bacterial infection, don't forget about this, can be very serious. Meningococcal infection, we will speak about this. A lot of, yes, the list of acute different tonsillitis, we will speak about them on practical classes. Diphtheria, we will remember about diphtheria during this lecture. And mumps also like belong to the, I have to change the place of mumps because it's influence exactly its viral infection and character for children. And a lot of another. Так, okay, now let's remember about possibility of such airdrop, aerosol, yes, mechanism of transmission. And what can we say about such mechanism of transmission? The first, yes, what I hope you remember from epidemiology, the first chain of epidemic process is the source of infection, and here you can see this one, the first egg, yes, it will be source of infection. As a rule, discharge the agent from the organism during expiration, sneezing, coughing, inhumanity, during conversation also can be, but remember that, yes, a lot of respiratory infections are anthropognosis, but for example, flu is this exception. It also can infect not only humans, but birds and other animals, mammals also. Birds, bats, and a lot of another animals, not only humans. Second, this arrow, it's the second chain of epidemic process. It's a mechanism of transmission, and here it will be airdrop or aerosol mechanism of transmission. And that's why respiratory infections by environment, in air, by drops of saliva and mucus. We will speak more exactly during influenza about this. And the third chain and second egg is the susceptible organism, penetration of the agent into the susceptible organism. As a rule, yes, by inspiration. Here you can see the very interesting epidemiological classification of the mechanism of transmission, by the mechanism of transmission and also by the possibility of transmission from the primary or secondary place of infection. Subgroup 1, the agents localized in the place of their penetration. It will be during measles, whooping cough, and flu exactly. Subgroup 2, the agents from the penetration place can move, yes, into the deeper tissues during meningococcal infection, yes, can lead to the meningococcemia, very serious generalized process. Mumps, yes, can involve not only salivary glands, but also can involve pancreas, no, and another reticular endothelial system organs. The transmission from the secondary affected organs is impossible because, as a rule, you will never catch infection like mumps from pancreas, if it will be in pancreas, or, for example, meningococcal infection. It will not be nasopharyngeal form, or it will be like already meningitis. As a rule, you will never catch this infection from the patient. But still, you have to be very careful. Subgroup 3, the penetration of the agent into the bloodstream, the formation on the skin and the mucus, the specific lesions that consist the agent. Theoretically, at their alteration, the contamination can occur. During chickenpox, smallpox, for example, yes, you can catch the infection. It's not the primary place of the infection, this rash and vesicles on skin. No, primary infection will be on the respiratory tract. But yes, it's secondary and it's very character symptom for chickenpox. And really, if patient will scratch this, for example, this rash, these vesicles, and appear the fluid from these vesicles, and you will touch also this, and then will touch your eyes, your nose, your mouth. Yes, you can catch this infection if you are not immune. And subgroup 4 can be transmitted not only by air, but also another factors contaminated by contiguous discharging, like household articles, dishes, toys, foods, water. It character for diphtheria, for scarlet fever, for poliomyelitis, and a lot of another. I hope you understand it. You can catch this infection not only exactly from patient, but also from different things that the patient touched before. Peculiarities of epidemic process. As a rule, all these infections are pure anthraconosis except flu, but exception proves the rule. Infection at the direct meeting the source. As a rule, but also exceptions present, like this subgroup 4, yes, like during diphtheria, scarlet fever, and so on. Child infection or children infections. As a rule, the patients are children. Like most of all these infections, yes, like measles, pertussis, chickenpox, rubella, scarlet fever, mumps, they all belong to so-called child infections because, as a rule, we all have had such infection in childhood, yes, or were vaccinated, and that's why we have immunity against them. Seasonality. Continuous stay in the closed room, the forming of new collectives. Believe me, it's not, no, also, yes, sure, the bad weather, cold weather decrease a little your local immunity in the, for example, in upper respiratory tract, yes, but it's not the main. A main will be the forming of new collectives. What does it mean? For example, students from all over the world come to Ternopil University, come to auditory for lecture, and can catch so many different infections at present all over the world. You understand, I hope. And cyclicity of epidemic process. What does it mean? It means that some infections produce the herd or collective immunity in the population, and if this collective immunity will decrease, again can be the increasing of morbidity. What exactly this means? Cyclicity. Why? Because, for example, if without immunization, measles can have such cycles each 6-10 years. For example, meningococcal infection can have such cyclicity like about 10-30 years. During such period, the collective immunity decrease, and that's why you can catch from any person, you can catch the infection. And you see now, yes, the situation with COVID, nobody has immunity against the COVID, yes, at the beginning of pandemic, and that's why each person is under the attack, each person. That's why, and we will see what will be. Will we produce the collective immunity as I see, for example, in Israel? Yes, they successfully going to the finish of vaccination, and the morbidity decreased very gradually. About just 200 patients now present in all Israel with COVID. Social factors that influence on the development of epidemic process at aerosol anthroponosis. Density of population. Yes, if the density is very high, yes, it's very easy to catch from another person the infection. Infant natality. As a rule now, each infant is stay alive, and it lead as a rule to the very high, very serious increasing of possible different immunological problems and so on. That's why such persons really can be immunocompromised from the beginning of their life, and that's why can catch the infection very easy. The forming of organized collectives, as already we spoke about this. Migration, it's like the same, yes. Organization of vaccination, because vaccination is one of the most important situation in the prevention and in the forming of collective or herd immunity against a lot of such infection that can be prevented. And now we will start speaking about the diseases exactly, and as you see, I hope fast, and it is one of the most dangerous and one of the most often is influenza, and synonyms flu, grippe. Yes, it's acute viral illness with the direct mechanism of transmission of the agent, drop mechanism of transmission. Distribution is epidemic and pandemic can be, and it is characterized by the infection of respiratory tract, expressed intoxication, fever, and moderate catarrhal phenomena. Key facts. Influenza is an acute viral infection that spreads easily from person to person. Influenza circulates worldwide and can affect anybody in any age group. Influenza causes annual epidemics that peak during winter in temperate regions. Influenza is a serious public health problem that causes severe illnesses and deaths for higher risk populations. An epidemic can take an economic toll through lost workforce productivity and strained health services. Vaccination is the most effective way to prevent infection. Classification and pathogenesis. There are 4 types of influenza viruses termed influenza virus A, B, C, and D. Aquatic bats are the primary reservoir of influenza A virus, which is also widespread in various mammals, including humans and pigs. Sorry. Influenza B virus and influenza C virus primarily infect humans, and influenza D virus is found in cattle and pigs. Influenza A and B viruses circulate in humans and cause seasonal epidemics, and influenza C virus causes a mild infection primarily in children. D virus can infect humans but is not known to cause illness. In humans, influenza viruses are primarily transmitted through respiratory droplets produced from coughing and sneezing. Transmission through aerosols and intermediate objects and surfaces contaminated by the virus also occur. We will speak about this a little later. Together, all these viruses, A, B, C, D, yes, which are antigenically distinct from one another, comprise their own viral family, Orthomyxoviridae family. The structure of the influenza virus is somewhat variable, but the virion particles are usually spherical or ovoid in shape and about 80 to 120 nanometers in diameter. Sometimes filamentous forms of the virus occur as well and are more common among some influenza strains than in others. The influenza virion is an enveloped virus that derives its lipid bilayer from the plasma membrane of a host cell. Two different varieties of glycoprotein spike are embedded in the envelope. Approximately 80% of the spikes are hemagglutinin, a trimeric protein that functions in the attachment of the virus to a host cell. The remaining 20% or so, yes, of the glycoprotein spike consist of neuraminidase, which is thought to be predominantly involved in facilitating the release of newly produced virus particles from the host cell. On the inner side of the envelope that surrounds an influenza virion is an antigenic matrix protein lining. Within the envelope is the influenza genome, which is organized into 8 pieces of single-stranded RNA. A and B forms only 8, yes. Influenza C has, what you see, structural proteins. Influenza C has 7 RNA segments. The RNA is packaged with nucleoprotein, yes, no, it's here, like nucleoproteins, into a helical ribonucleoprotein form with 3 polymerase peptides for each RNA segment. Here we can see the life cycle. For example, yes, H1N1 swine influenza, in other words, yes, swine influenza viruses, but it's like the same for all viruses, influenza viruses. The influenza virus attached to its target cell, yes, not here, target cell, surface cells of the nose, throat, or lungs, its epithelial cells, mucosal epithelial cells of upper respiratory tract, using its hemagglutinin antigen. You see here, yes. Once attached to the target cells, the influenza virus is engulfed into the target cell. What you can see here, yes. At this point, while engulfed in the target cell, the influenza virus cell releases its genetic material, you see RNA, into the cell. This RNA or ribonucleic acid travels, what you see here, yes, to the nucleus where it replicates itself. Not here. New RNA, yes, acids here appear. Viral messenger ribonucleic acid or mRNA causes the cell make new viral proteins. It will be like here, yes. All this RNA, mRNA, viral mRNA, go to the such endoplasmatic reticulum and produce new viral proteins. The newly replicated viral RNA and the new viral proteins assemble themselves at the cell surface, forming a new viral particles. What you see here, yes. Using its neuraminidase antigen, the forming, what exactly neuraminidase, you understand? Yes, involved. Antigen, the forming viral particles attached to the sialic acid receptors on the host cell's interior, and the budding process begins. Right here. Yes, and all this lipid membrane, all from the host cell. A new influenza viral virus has been formed and is free to infect more cells and replicate itself. Very simple, easy, but very effective possibility of development of replication. Influenza A virus is responsible for most cases of severe illness, as well as seasonal epidemics and occasional pandemics. It infects people of all ages, but tends to disproportionately cause severe illness in the elderly and very young, and those who have chronic health issues. Birds are the primary reservoir of influenza A virus, especially aquatic birds such as ducks, geese, shorebirds, and gulls. But the virus also circulates among mammals, including pigs, horses, and marine mammals. Influenza A virus is classified in two subtypes based on the viral protein hemagglutinin and H and neuraminidase. Yes, you see here. And as of 2019, 18 hemagglutinin subtypes and 11 neuraminidase subtypes have been identified. Most potential combinations have been reported in birds, but hemagglutinin 17-18 and neuraminidase 10-11 have only been found in bats, like flying mammals, yes. Only hemagglutinin subtypes H1, H3 and N subtypes N1 and 2 are known to have circulated in humans. Only 3 hemagglutinins and 2 neuraminidase in humans. The current influenza A virus subtypes in circulation being H1N1 and H3N2. Influenza A viruses can be classified more specifically to also include antigenic structure. Yes, you see here. Type of virus understanding, natural host species, duck, yes, here, it's example, geographical origin, strain or isolation number, in other words, also, and year of isolation. It's 1976, you see here. Here another examples, as you see also, and here also you can see the B variant, yes, and influenza B virus mainly infects humans, but has been identified in seals, horses, dogs, and pigs. Influenza B virus does not have subtypes like influenza A, but has two antigenically distinct lineages. Tempt, you see, B Victoria, Victoria like lineages, and B Yamagata like lineages, or simply B Victoria like and B Yamagata like. Both lineages are in circulation in humans, disproportionately affecting children. Influenza B viruses contribute to seasonal epidemics alongside influenza A viruses, but have never been associated with pandemic. Influenza C, like influenza B, is primarily found in humans, so it also has been detected in pigs, feral dogs, dromedary camels, cattle, and dogs. Influenza C virus infection primarily affects children and is usually asymptomatic, or has mild cold-like symptoms, so more severe symptoms such as gastroenteritis and pneumonia can occur. Unlike influenza A and B, influenza C virus has not been a major focus of research pertaining to antiviral drugs, vaccines, and other measures against influenza. Influenza C virus is subclassified into 6 genetic or antigenic lineages. Influenza D virus, yes, has been isolated from pigs and cattle, the latter being the natural reservoir. Infection has also been observed in humans, horses, dromedary camels, and small ruminants such as goats and sheep. Influenza D virus is distantly related to influenza C virus. While cattle workers have occasionally tested positive to prior influenza D viral infection, it is not known to cause disease in humans. Influenza C and influenza D virus experience a slower rate of antigenic evolution than influenza A and B. Because of this antigenic stability, relatively few novel lineages emerge. Now we have to speak about very interesting possibilities of influenza A virus. It's like drift and shift, two key processes that influenza viruses evolve through the antigenic drift and antigenic shift. Antigenic drift is when an influenza virus antigens change due to the gradual accumulation of mutations in the antigens, hemagglutinin A or neuraminidase A gene. This can occur in response to evolutionary pressure exerted by the host immune response. Antigenic drift is especially common for the hemagglutinin protein, in which just a few amino acid changes in the head region can constitute antigenic drift. The result is the production of a novel strain that can evade pre-existing antibody-mediated immunity. Antigenic drift occurs in all influenza species, but slower in B viruses than A, and slowest in C and D. Yes, it also can be, but as a rule, it's under the even research. Antigenic drift is a major cause of seasonal influenza and requires that flu vaccine has be updated annually. Hemagglutinin is the main component of inactivated vaccines, so surveillance monitors antigenic drift of this antigen among circulating strains. Antigenic evolution of influenza viruses of humans appears to be faster than influenza viruses in swine and equines. In wild birds, within subtype antigenic variations appear to be limited, but has been observed in poultry. Antigenic shift. What does it mean, shift, antigenic shift? It's also very dangerous, not also, it's one of the most dangerous because exactly due to shift can be pandemics. Antigenic shift is a sudden, drastic change in an influenza virus's antigen, usually hemagglutinin. During antigenic shift, antigenically different strains, can you see? Yes, antigenically different strains can infect the same cell and can reassort genome segments with each other, producing hybrid progeny. Since all influenza viruses have segmented, yes, you see, segmented genomes, all are capable of reassortment. Antigenic shift, however, only occurs among influenza viruses of the same genus and most commonly occurs among influenza A viruses. In particular, reassortment is very common in avian influenza viruses, creating a large diversity of influenza viruses in birds, but is uncommon in human, equine, and canine lineages. Pigs, bats, and quails have receptors for both mammalian and avian influenza A viruses, so they are potential mixing vessel for reassortment. Yes, remember, pigs, bats. If an animal strain reassorts with a human strain, then a novel strain can emerge that is capable to human transmission. This has caused pandemics, but only a limited number have occurred. So it is difficult to predict when the next will happen, but as you see, also appear coronaviruses, and we will have another possibility of prediction. So widespread familiarity with the flu makes it seem relatively benign to much of the general population. The virus can be devastating. In 1918-1919, more than 20 million people died. No, we will speak a little later about this. Epidemiology and transmission. Influenza viruses A and B cause annual outbreaks. As you see, yes, the source of infection can be healthy person in the latent period, patient during whole period of the disease. Disease as a rule lasting 7 days. Recovery, it is proved that in individuals the virus can be conserved up to 14-15 days. And sure, the source can be birds. Don't forget about possibility of avian influenza. Influenza viruses A and B cause annual outbreaks of illness affecting approximately 5 to 10% of adults, with high rates in children. The appearance of a new strain, for which most of the population lacks immunity, can result in worldwide outbreaks or pandemics. Pandemic strains are associated with global spread over months and with high attack rates. 3 such pandemics occurred during the 20th century. The most severe was the Spanish influenza pandemic in 1918 and 1919, which caused from 20 to 40 million deaths worldwide. Epidemic influenza occurs annually in temperate areas, typically between the months of December and March in the Northern Hemisphere, and follows the reintroduction of virus each year. Influenza activity usually occurs in May through August in the Southern Hemisphere and can be year-round in the tropics. Regional outbreaks caused by a particular strain are usually short from 6 to 8 weeks. Also, successive waves of infection by different influenza viruses can occur. Influenza activity in the community is marked by increased medical contacts for febrile respiratory illness, increased absenteeism in schools and the workplace, subsequent increased hospitalization for pneumonia and other cardiopulmonary disorders, and increased mortality. Pneumonia hospitalization increased by 2 to 5 times in high-risk patients. Persons 65 years of age and older constitute nearly 50% of excessive hospitalization and over 85% of deaths from influenza. Influenza viruses are transmitted principally via large and small aerosolized particles. As you see here, yes, large and small aerosolized particles. Direct transmission of influenza A virus to humans from animals has been documented. Although animal-to-human transmission has typically been from swine, direct transmission from birds caused an episodic of avian influenza A H5N1 subtype virus in Hong Kong and Southeast Asia, with several dozen human infections, many of which were fatal, and a lot of another subtypes also possible during the very close contact with birds. People who are infected can transmit influenza viruses through breathing, talking, coughing, sneezing, which spread respiratory droplets, yes, see, and aerosols that contain virus particles into the air. A person susceptible to infection can then contract influenza by coming into contact with these particles, like here. Respiratory droplets are relatively large and travel less than 2 meters before falling onto nearby surfaces, like here. Aerosols are smaller and remain, yes, suspended in the air longer, so they take longer to settle and can travel further than respiratory droplets. Inhalation of aerosols can lead to infection, but most transmission is in the area about 2 meters around an infected person, via respiratory droplets that come into contact with mucosa of upper respiratory tract. Here. Transmission through contact with the person, body fluids, or intermediate objects like vomits, yes, can also occur, such as through contaminated hands and surfaces, since influenza viruses can survive for hours on non-porous surfaces. if one's hands are contaminated, like here, yes, then touching one's face can cause infection. Clinical features. The incubation period for influenza virus is short, averaging 2 days, about 2 days, range from 1 to 4 days. Classic influenza is distinguished by abrupt onset of prominent systemic symptoms, including fever, chills, headache, myalgia, malaise, and anorexia. So fever usually lasts for an average of 3 days in adults. Sore throat, dry cough, photophobia, and pain on eye movement occur frequently early in the illness. Mild conjunctivitis, clear nasal discharge, pharyngeal injection, and small tended cervical lymph nodes are also common. As systemic illness abates, respiratory symptoms become more apparent. The most troubling respiratory symptom is protracted cough, which results from viral tracheobronchitis. Airway hyperactivity and abnormalities in pulmonary function may last from weeks to several months in previously healthy persons. Exacerbation of asthma and other types of pre-existing airway diseases are often severe. Infection may be subclinical or cause mild illness, including colds. Primary influenza virus pneumonia is a heterogeneous condition ranging from mild disease, which patchy infiltrates, to rapidly fatal infection. Severe pneumonia generally account for 2% of influenza-associated pneumonia, but during pandemics, it can account for about 20%. Influenza A viruses cause more than 90% of all cases. As many as 40% of patients with influenza pneumonia have no prior underlying disease. Pneumonia usually begins with typical influenza, following within 1 to 3 days by rapidly progressive dyspnea, cyanosis, diffuse rales, and wheezing. Pleuritic chest pain and blood-tinged sputum or frank hemoptysis occurs. Patients with influenza virus pneumonia have a high mortality. Here you can see the classification by international health, international disease classification, and marked by J10, and by types of virus, by clinical forms, typical, atypical, can be by severity, you understand, and also different complications can be. Here you can see one of the very interesting pictures of phases of exactly pandemic. Influenza pandemic in this case, in this situation on this slide, but also all pandemics go through all these phases. And you see the first phase, yes, is predominantly, first it's like this gray square, yes, a phase from 1 to 3, predominantly animal infections, and just few human infections can be like, yes, like avian influenza possibility. Phase 4, sustained human-to-human transmission. What appears the new genetic strain of virus. Yes, it was reassorted in the mammals, like pigs, like dogs, and so on, and already appears a possibility of human-to-human transmission. And here you can see, yes, already red square, phases 5, 6, already present pandemic, widespread human infection. Sure, in some time, yes. No, during influenza, as a rule, it's more quickly, but during COVID, we have very long quarantine situation. But believe me, it's the Spanish flu, yes, in 1918-19. Also, it took about 2 and even more, even 3 years to go to this already blue. Yes, it's like blue, like color of hope, post-peak situation, possibility of recurrent events, but already the top of all this pandemic development is in the past. And also post-pandemic, the light blue square, this activity at seasonal levels that we have now such situation with H1N1 that was pandemic in 2009-2010. I hope maybe you remember, yes, was pandemic of influenza, swine influenza, yes, was such name, but believe me, it's not swine, it's really like human H1N1 virus, A virus. Так, testing, laboratory test of influenza, also very interesting and a lot of possibilities already present. Diagnostic methods that can identify influenza include viral cultures, antibody and antigen detecting tests, and nucleic acid-based tests. Viruses can be grown in a culture of mammalian cells or embryonated eggs for 3-10 days to monitor cytopathic effect. Cultures can be used to characterize novel viruses, observe sensitivity to antiviral drugs, and monitor antigenic drift. But they are relatively slow and require specialized skills and equipment. No, yes, viral culturing, you understand. It's very serious and severe process. Serological assays can be used to detect an antibody response to influenza after natural infection or vaccination. Common serological assays include hemagglutinin inhibition assays that detect hemagglutinin-specific antibodies, virus neutralization assays that check whether antibodies have neutralized the virus, and enzyme-linked immunoabsorbance assays. These methods tend to be relatively inexpensive and fast, but are less reliable than nucleic acid-based test. Direct fluorescent or immunofluorescent antibody test involves staining respiratory epithelial cells in samples with fluorescently labeled influenza-specific antibodies, followed by examination under a fluorescent microscope. They can differentiate between immunoglobulin A and influenza A and influenza B viruses, but cannot subtype influenza A viruses. Rapid influenza diagnostic tests are a simple way of obtaining assay result, are low cost and produce results quickly at less than 30 minutes. So they are commonly used, but they cannot distinguish between A and B or between influenza A viruses subtypes and are not as sensitive as nucleic acid-based tests. No, and at the last, yes, the most sensitive and the most sensitive test, nucleic acid-based test. Amplify and detect viral nucleic acid. Most of these tests take a few hours, but rapid molecular assays are as fast as rapid influenza diagnostic tests. Among nucleic acid-based tests, reverse transcription polymerase chain reaction is the most traditional and considered the gold standard for diagnosing influenza because it is fast and can subtype influenza A virus, but it is relatively expensive and more prone to false positives than cultures. Other nucleic acid-based tests that have been used include loop-mediated isothermal amplification-based assays, simple amplification-based assays, and nucleic acid sequence-based amplification. Note here you can see the preliminary negative stain transmission electron micrograph depicts some of the ultrastructural morphology of the swine flu virus. Treatment after diagnosing, as a rule, we are going to the treatment. Antiviral drugs are preliminarily used to treat severely ill patients, especially those with compromised immune system. Antivirals are most effective when started in the first 48 hours after symptoms appear. Late administration may still be beneficial for those who have underlying immune defects, those with more severe symptoms, or those who have a high risk of developing complications if these individuals are still shedding the virus. Antiviral treatment is also recommended if a person is hospitalized with suspected influenza instead of waiting for test results to return and if symptoms are worsening. Most antiviral drugs against influenza fall into two categories: neuraminidase inhibitors and matrix protein ion channel inhibitors. Baloxavir marboxil is a notable exception which targets the endonuclease activity of the viral RNA polymerase and can be used as an alternative to neuraminidase and matrix 2 inhibitors for influenza A and B viruses. Neuraminidase inhibitors target the enzymatic activity of neuraminidase receptors, mimicking the binding of sialic acid in the active site of neuraminidase on influenza A and B variants, so that viral release from infected cells and the rate of viral replication are impaired. Neuraminidase inhibitors include oseltamivir, which is consumed orally in a prodrug form and converted to its active form in the liver, and zanamivir, which is a powder that is inhaled nasally. Oseltamivir and zanamivir are effective, as you see, are effective for prophylaxis and post-exposure prophylaxis. And research overall indicates that neuraminidase inhibitors are effective at reducing rates of complications, hospitalization, and mortality and the duration of illness. Additionally, the earlier neuraminidase inhibitors are provided, the better the outcome. So, late administration can still be beneficial in severe cases. Other neuraminidase inhibitors include laninamivir and peramivir, the latter of which can be used as an alternative to oseltamivir for people who cannot tolerate or absorb it. The adamantines, amantadine and rimantadine, are orally administered drugs that block the influenza virus M2 ion channel, preventing viral uncoating. These drugs are only functional against influenza A virus, but are no longer recommended for use because of widespread resistance to them among influenza A viruses. Adamantine resistance first emerged in H3N2 in 2003, becoming worldwide by 2008. Oseltamivir resistance is no longer widespread because the 2009 pandemic H1N1 strain, which is resistant to adamantines, seemingly replaced resistant strains in circulation. Since the 2009 pandemic, oseltamivir resistance has mainly been observed in patients undergoing therapy, especially the immunocompromised and young children. Oseltamivir resistance is usually reported in H1N1, but has been reported in H3N2 and influenza B viruses less commonly. Because of this, oseltamivir is recommended as the first drug of choice for immunocompetent people, whereas for the immunocompromised, oseltamivir is recommended against H3N2 and influenza B virus, and zanamivir against H1N1. Zanamivir resistance is observed less frequently. Influenza pneumonia. Treatment of influenza virus pneumonia is primarily supportive. Improvements in assisted ventilation techniques have raised the survival rate about 50%. Also, pulmonary fibrosis developed in some patients. M2 inhibitors, neuraminidase inhibitors, and aerosolite intravenous ribavirin, which is active against influenza A and B viruses, have been used with uncertain benefit. Combination therapies, for example, M2 inhibitors plus neuraminidase inhibitor for influenza A, show enhanced activity in animal models. Although unstudied, the use of neuraminidase inhibitors, either alone or in a combination with other agents, seems reasonable in the treatment of influenza virus pneumonia. Prevention. Hemoprophylaxis. Antiviral hemoprophylaxis with amantadine or rimantadine is about 70 to 90% effective in preventing illness caused by influenza A virus. Hemoprophylaxis can provide several weeks protection to patients immunized after influenza A activity has begun. Can be given throughout the season to those who cannot receive influenza vaccine, for example, those with egg allergy, or who are unlikely to respond to the vaccine, or can be used for protection of high-risk persons when the epidemic strain diverges significantly from the vaccine antigens. Side effects of amantadine are gastrointestinal upset and minor reversible central nervous system symptoms like insomnia, dizziness, and difficulty with concentration. Rimantadine appears to be equally effective as amantadine and is associated with a lower risk of central nervous system side effects. The neuraminidase inhibitors are also effective for prophylaxis of influenza A and B infections. Both inhaled zanamivir and oral oseltamivir prevent influenza when used for seasonal prophylaxis or after exposure. For example, for family of nursing home contacts. But only oseltamivir has been approved by Food Drug Administration for this indication. Oseltamivir has been found to be safe for treatment of children as young as 1 year. Inhaled zanamivir has been found to be safe in children as young as 5 years. Of note, both the M2 and the neuraminidase inhibitors may reduce the efficacy of live attenuated influenza vaccine if the vaccine and the antiviral agent are given together. Immunization. Influenza vaccines are available in two forms: an intramuscular preparation containing formalin inactivated virus and purified surface antigen, and also an intranasal spray containing live attenuated viruses. Both are made from egg-grown virus. Vaccine composition is reviewed annually and adjusted to reflect changes in antigenicity and anticipated circulation of viral strains. Current vaccines contain 1 influenza B and 2, but as a rule, 2 influenza B and 2 influenza A, H1 and H3 subtypes. It's like quadrivalent vaccine. The efficacy of these vaccines is approximately from 70 to 90%. No, it's the best situation in young adults, especially when the vaccine antigen and the circulating strain are closely matched. Immunization in healthy working adults is associated with fewer upper respiratory illnesses and fewer visits to physicians' offices. The intranasal vaccine is currently approved only for healthy persons from 5 to 49 years of age. It appears to be less effective in the elderly, but possibly superior to inactivated vaccine in young children. Immunization with inactivated vaccine reduces influenza-related hospitalizations and reduces mortality in ambulatory elderly patients by 40 to 60%. Wide-scale immunization of school children may reduce influenza-related mortality in older adults. Also, inactivated vaccine is less effective in infirm elderly patients. It provides partial protection against pneumonia and death. The highest priority for vaccination should be given to persons at increased risk for influenza-related complications and their contacts. Administration of the inactivated vaccine is associated with soreness at the injection site in as many as 1/3 of recipients, but fever or systemic reactions are uncommon in adults. Influenza vaccination does not adversely affect CD4 cells, T cells counts or accelerate progression to AIDS or death in HIV-infected patients. The intranasal vaccine causes transient coryza and sore throat. Vaccine viruses are recoverable from nasal samples in low titers for up to 1 week in adults and are genetically stable. Although viral transmission is rare between children and has not been documented in adults to date. Vaccine recipients should avoid close contact with highly immunocompromised hosts. For example, stem cell transplant recipient for 1 week after immunization. And now I want to show you, yes, to the end of our discussion of influenza. I want you to watch short movie, historical moments of Spanish influenza, and maybe it will looks like similar that we have now.
I had a little bird, its name was Enza. I opened the window and influenza.
Perhaps until recently, Spanish flu has been what some people call a forgotten pandemic. But it was a huge global calamity. In terms of the number of deaths, we're saying 50 to 100 million, far greater than the casualties of the First World War. Roughly around April, May 1918, when, the carnage of the First World War is graphic and horrendous. But at the same time, this unknown enemy is starting to sweep through the US, Europe, the trenches, and it is recorded by the Spanish press, and it becomes dubbed as the Spanish flu because they are neutral. Well, at the time in the 1920s, they estimated that maybe 20 million had died. By the late 20th century, that figure had been up to 25 million. In the 21st century, with scientists and historians now getting together to work much more closely, that figure has now been upped to 50 to 100 million people killed. This virus killed more people in the first 25 weeks than HIV/AIDS has killed in 25 years. Horrendous. I mean, those mortality statistics are staggering.
We don't know exactly why some flu strains are much more severe than others and why some of them would be more likely to kill people or cause very severe disease.
What is particular about avian and pandemic viruses is that they replicate deep inside our lungs. When our cells detect this and trigger a very strong innate immune response, this leads to an influx of white blood cells and fluids into our lungs, and it restricts the amount of airspace that we have to breathe.
The symptoms are very graphic and very, very striking. So, it's said that some people drowned in their own phlegm. So if it was hitting or affecting the lungs, people were spurting blood from their ears and their noses. Descriptions of people turning blue or purple. So, it was really, really severe. And people just dropping down in the streets. Those that succumbed to the flu were in the age group 20 to 40 years, which is very unusual for an influenza epidemic or pandemic. And scientists and historians are now still looking to see why.
There's really two ways that people died in 1918. They either died from the initial flu infection, or they died from an enormously strong immune response to that virus where their lungs just filled up with fluids from trying to attack the virus that got into their lungs.
So traditionally, everyone sort of said, oh, well, it's the trenches, and, the conditions of the war, and that's why it was so fatal. But then you think, well, how did it spread so rapidly around the world to places that are not part of the theatre of war? I think the traditional explanation is it starts in Kansas, in an army camp, and then the troops bring it over to the trenches, Europe. But there's still many, many unknowns.
So mathematical modellers have long been interested in the 1918 pandemic, and one of the questions is to try and disentangle how it spread around the world and exactly what the routes have been. Given perfect data, you could work backwards and try to infer where it's come from. Whereabouts does it arrive in a country? Does it arrive multiple times? Or thinking about multiple countries, where is the first place? If you understand the origin of a pandemic, then you understand something about where it's come from, and maybe you can stop that in future.
Almost certainly it was a bird flu originally. But then We also know that that flu, or something very similar to it, was in pigs at the same time. Maybe it's somebody who works very closely with birds, or who works very closely with pigs, or has some other exposure like that. One of the big, really open questions in flu research and flu public health is, how does the virus adapt from one species to another? How does, for example, a virus in pigs or in birds get into humans and then start transmitting? Then the key question is, how does the virus then adapt within that person to stop being a pig virus or a bird virus and become a human virus? In other words, to be able to transmit from human to human. And it's probably some very quick evolutionary process that is going on within that human, and in many cases won't be successful, but in a few cases will, and that's when the virus can start spreading between humans and become a flu pandemic, and then stay in humans as regular seasonal flu.
Just as people were celebrating Armistice Day, and there was hope that it was dying down, but then it resurged. A far more deadly and virulent strain emerged. So this second wave really spread like wildfire, affecting a third or a quarter of the population of the world. And it was short-lived, so it petered out not long afterwards, maybe 1920, 1921. But it was in the sense short-lived.
What happened is that virus continued to transmit among humans. In fact, it continued until 1957 to transmit between humans. And probably what happened there is that the virus adapted to humans. It wasn't this avian or swine virus that came in and was accidentally more pathogenic in humans. In our lab here in Cambridge, we study both seasonal flu and pandemic flu from the standpoint of how does the virus evolve, and how can we predict that evolution and make vaccines to try to artificially evolve the virus both in the laboratory and in the computer to understand what it's going to do next and to make vaccines against those strains that will evolve in the future. So this is the basic science of studying evolution and trying to predict that evolution, something that nobody's ever been able to do for a complex organism. And then working to use that understanding to make better vaccines. On the pandemic flu side, we do a similar thing where we look to see how that virus is changing, that virus, how it changes in birds and how it changes how that virus changes in other species, and to try to see what possible variants out there might be. And again, to make vaccines that could protect against all of those variants that we see.
Flu is very difficult to eradicate because it's constantly mutating and changing its genetic information. We work on the influenza virus, and in particular on the enzyme that copies the genetic information of the virus when it enters our cells. Specifically, we're interested in how this enzyme can do this activity and how it inserts mutations in the viral genome that leads to the formation of new strains to which we need to develop new vaccines. And we are also interested in when this enzyme messes up, how it triggers the innate immune system and helps cause disease.
We really don't know why we haven't seen a pandemic as deadly as the 1918 pandemic. Scientists and public health officials are extremely concerned. The National Risk Register, which is the way that our government plans what are all the risks to civil society in the UK, there's only 2 events that are up there in terms of the most catastrophic, and that's a terrorist event or a influenza pandemic. There is a real threat that there can be such pandemics. For example, the H5 and the H7 flu viruses that have infected now close to 2,000 people and killed about half of them. There has been with the H7 viruses some transmission from human to human, not very efficient, and it hasn't really taken off. If either of those viruses did adapt to really transmit well between humans, there's a real concern that it could be as bad as the 1918 virus. And this is why there is so much research done for the public good to try to understand what's happening, and so much work done by people in public health and preparing in hospitals in case something like that happens.
Well, experts like to say it's not if, but when. coming as a mathematician, it's happened a lot of times in the past. It will probably happen again. The 1918 pandemic is difficult because of lack of data, but the most recent influenza pandemic we had was in 2009. And from that pandemic, there is some very good data. If we understand how the 2009 pandemic spread, maybe that tells us something we can use to help control future pandemics. If we can't stop them, the alternative is at least to allocate our resources better to try and reduce the number of cases in each place.
Looking back 100 years to the last pandemic also invites the question of 100 years from now, what will we be like in terms of how well we are protected against flu, or what things we could do to protect ourselves in some situations? Surely we'll be in a situation where we know more about what viruses are in the world and where they are. Surveillance will be so much better. Surely we'll be in a better situation where we have better drugs and better vaccines because we know more about the virus, so we know more about its weaknesses. We know more about our immune systems, and we know how to enable them to fight those pathogens better. At some point, we will have a universal vaccine that will protect us against flu for the rest of our lives. When this is a whole other question. There are a great number of approaches and really good ideas to doing this. There are already attempts at this that are at a quite advanced stage. It might be 10 years from now. It might be 20 or 30 or 40 years from now. We really don't know.
No, as you understand, now we have really not influenza epidemic or pandemic. We have pandemic of coronavirus infection, exactly, yes, and really we can predict such possibility. We could predict such possibility because was SARS, was MERS, yes, severe acute respiratory syndrome, was Middle East respiratory syndrome, and now we have also very serious coronavirus disease 19 that show us that infectious diseases still present, and they will live and go with us all our history, and I think all our today and all our future. We have to be ready, but as all this situations that we have in the world now show that we were not ready, and I'm not sure that we will be. Okay, that's all about influenza, but quickly some words about bacterial infections that still can be very serious, very dangerous for humans, and can cause the generalized or very serious diseases like meningococemia or meningitis, and one of them meningococcal infection. Epidemiological characteristics. The morbidity rate is not high. The duration of generalized forms is severe with high invalidity and mortality. The source health carrier on nasopharyngitis patients, 20% of all possible, and generalized form, yes, you see just 1%, and you see the correlation ill to carriers 1 to 2,000. That's why epidemiologically it can be very dangerous, and this one yes of 2,000 can lead to the generalized form that can be very, very serious. For the infection is needed close and long time contact conversation with the source, not further than half a meter. Among patients dominate children, yes, because immunity absence. Seasonality February, April. Cyclicity 10-30 years, as I told you. Incubation period about 2-10 days. Clinical forms can be nasopharyngitis, meningococemia, and purulent meningitis. Hospitalization, the directions are clinical and epidemiological. The hospitalization in the separate room is enabled. It's not necessary into the box. the times of discharging, the clinical recovery, the admission into the collective after one control bacterial investigation on the meningococcal carriage in 5 days after discharging from the hospital. The dispensary control, like the observation by infectious diseases doctor, by neurologist, by after generalized forms, will be 2 years. Meningococcal infection. The laboratory confirmation of the diagnosis. Detection of agent in the smear from oropharynx, blood, spinal fluid. Intake the material from oropharynx by care sterile wedding plug. Do not touch mucus because lysosine will lead to the killing of meningococcus, yes, Neisseria meningitis. Deliver it into the laboratory at the temperature about 35-37 degrees because the temperature rate is very serious in the more lower temperatures. Also, meningococcus will die. Sewing on the medium with the adding of proteins. At microscopy, gram-negative diplococci, yes, situated intracellular and serological. Here you can see, yes, diplococci from 2 parts, like coffee beans. Serological investigation of blood in dynamics, yes, 2 pairs serums with interval 5-7 days and increasing of titer in 4 times. Anti-epidemic measures in the place of outbreak at the collective disease and in the closed collectives, quarantine 10 days, and each day you have to make thermometry, EMT examination, bacteriological investigation, children twice and adults just 1 time. Sanation of detected carriers. Vaccination by the epidemic directions. And now in some countries, vaccination against meningococcal infection is included in immunization schedules. It's why, but in Ukraine, still not present. Diphtheria, very quickly, another one, bacterial infections that can lead to very serious, as you see here, involvement of upper respiratory tract and can lead even to the croup, direct croup, yes, real croup. And what does it mean? It's like the lead to the dyspnoea and even to full asphyxia. Is an acute infectious disease caused by Corynebacterium diphtheria or another Leffler bacilli. Leffler is the first scientist who discovered the agent of diphtheria, transmitted mainly in air drop way and characterized by the symptoms of general intoxication, local inflammation of the mucous membranes, mainly with the formation of fibrinous films and typical complication of the nervous and cardiovascular system. It's controlled infection, yes, because all over the world the diphtheria vaccination against the diphtheria is included in the immunization schedule. Source, ill person, convalescent or carrier. Ways of transmission ways can be a lot of, but main mechanism is airdrop mechanism. And remember that yes, it can be transmitted by the additional articles like vomits. Susceptibility is high. 80% of patients is susceptible at the direct contact, and can lead to very serious also adults and incorrectly vaccinated children. Yes, 80% at contact as a rule can catch the disease if they are not immune. Immunity can produce immunity, anti-toxic immunity, single for all types of agent, post-vaccinal. Antibacterial cross-immunity is absent. Incubation period 2 to 10 days in average. Clinical forms: diphtheria of oropharynx, nose, larynx, trachea, and bronchi. Rare localization can be nose, yes, you see. Hospitalization immediate into the separate room. Treatment specific, don't forget, because only specific treatment can help. Anti-diphtheric serum. Also, yes, etiolotropic and pathogenic. Laboratory diagnosis: the detection of the agent in the smears from oropharynx and nose. Intake of the material on the border of film and healthy tissue. Microscopic coloring by Neisser, you see here. Yes. Typical location of the rods, like wide apart fingers, or in other words, like letter V, big letter V, capital letter. The sowing of material on the coagulated serum or blood agar. Serological reactions represent only the state of preceding immunity, effectiveness of vaccination, in other words. Terms of discharging: clinical recovery, yes, 2 negative results of control bacteriological investigation on Bacillus leufleri or Corynebacterium, yes, with 2 days interval in 2 days after cancelling of antibiotics. Admittance to the professional ability after twice additional bacteriological investigations on Bacillus leufleri in the outpatient's conditions. Dispensary control 1 year with at complication cardiologist and neurologist, because such complication can be present at diphtheria. We will speak about such diseases like meningococcal infection and diphtheria more carefully on practical classes, and if you will have questions, we will discuss them. Prophylaxis of diphtheria, I hope you remember, yes, it is included, yes, vaccination against diphtheria in the immunization schedule, and exactly what you see here, 3, 4, 5, 18 months, 6, 14, 18 years, 22, 23, and each 10 years you have been revaccinated. In spite of the recovery after diphtheria, the immunization is needed to continue in normal regime. Anti-epidemic measures in the needles of place of outbreak: observation by the contact 7 days, ENT examination, bacteriological investigation, sanation of the carriers, and revaccination if it needed. Thank you for attention. That's all for today. And if you have some questions, you are welcome.